I would now like to turn the conference over to Mr. John Gould, partner at Arnold and Porter LLP. Please proceed, sir.
Thank you. Welcome, everyone, to our webinar on 340B covered entity compliance and manufacturer audits. These are important topics, and we feel this is a great time to be talking about them. 340B has literally been making news lately, which is not a common occurrence, and interest in these topics really has been growing, along with 340B program enrollment. So we're excited to be here wherever we are in cyberspace talking to you, and I hope you're excited too. So let's get started. We'll start with some quick introductions. With you for the next hour will be me, John Gould, as well as Jonathan Connell and Partha Chatterjee. I'm a partner at Arnold & Porter and the FDA and Healthcare Group. I specialize in compliance counseling, contracting, drug price reporting, reimbursement, public policy advice, focusing on the pharmaceutical and biotech and device sectors, and this includes counseling in the 340B area. Jonathan Connell is an associate in the same group here at A&P, but he's based out of the New York office while I'm out of the DC office. And his practice focuses on the same areas. He has over 12 years experience in the life sciences industry, and before law school, he worked as a management consultant in the drug industry, focusing on drug price strategy, compliance, and systems integrations. And then finally, we have Partha Chatterjee too. He's a managing partner at the Akara Group. He has over 15 years experience in the life sciences industry, advising manufacturers in a variety of areas, including contracting strategy, government pricing, and reimbursement and contract operations. And prior to founding the Akara Group, he was with IMS Health's Managed Markets Services Practice, Envision Consulting Group, and J&J. So with that out of the way, we'll move on to the presentation itself. Our purpose here today is to discuss manufacturer audit rights and procedures under the 340B program, to talk about how manufacturers can establish reasonable cause, which is a requirement for conducting audits under HRSA's guidance, and also to provide some examples of the data analyses that manufacturers could perform in this area. Just by way of background, we'll touch briefly on some 340B program requirements, and we assume that if you're taking the trouble to tune in to an audit webinar, you already have some idea of what the relevant program requirements are. So we'll move through those fairly quickly and then on into the more interesting topics. We will save some time to answer questions at the end, and to do that, we will use the chat feature in the WebEx. So please ask your questions through that feature. We might not be able to get to all the questions during our hour, but please don't hesitate to contact one of us in follow-up should we not get your question answered here. And also, we wanted to let you know that we're recording this conversation, and it may end up posted to our website. In addition, we will be sending out to the attendees materials, the presentation slides, as well as some background documents. All right, well, we will launch now into the background on program requirements. We'll start with the requirements on manufacturers. Equal time for all here. Manufacturers have to sign a 340B pharmaceutical pricing agreement, also known as a PPA, to receive Medicaid or Medicare Part B reimbursement for their covered outpatient drugs. And in this PPA, the manufacturer agrees to charge 340B covered entities no more than the 340B ceiling price for covered outpatient drugs. And again, we'll move pretty quickly through this, but just so everyone's on the same page here. Covered entities include several types of hospitals, such as certain disproportionate share hospitals, children's hospitals, as well as federally qualified health centers, AIDS drug assistance programs, the list goes on. There's also here the 340B ceiling price. That's a deep discount that is tied to the Medicaid prices that manufacturers report under the Medicaid drug rebate program. Given how deep a discount this is, manufacturers have a strong incentive to make sure that they are not offering the discount where not necessary or where they don't choose to do it. So again, this is an interesting topic, the audits, how to make sure that the right entities are getting the right prices here. And again, this requirement to offer the 340B price applies to covered outpatient drugs, emphasis on the outpatient there. It's the same definition of that term as applies in the Medicaid rebate context. In other words, where a drug is used by a covered entity for an inpatient or in a circumstance where there's bundled payment, then that drug is not a 340B drug. And then finally, I'll touch on here ship-to, bill-to arrangements and what counts as a purchase by a 340B covered entity. It'll be relevant to some of the audit discussions that follow. HRSA guidance instructs that 340B covered entities can engage in a contract pharmacy arrangement, and those are arrangements where a covered entity purchases a 340B drug, and the 340B drug is shipped to a third-party pharmacy that's under contract with the covered entity. And then that third-party pharmacy then dispenses the drugs to the patients of the covered entity. And Jonathan will get into a bit more about some trends we've been seeing in the contract pharmacy space and more broadly with the 340B program. And then finally, rounding out the manufacturer requirements here, manufacturers can't discriminate against covered entities in their drug distribution. So, for example, if a manufacturer sells to commercial entities through a wholesaler, HRSA guidance instructs that the same must be true for the covered entities. So covered entities and their contract pharmacies are required to maintain auditable records sufficient to demonstrate that they are complying with 340B program requirements, which then begs the questions, what exactly is required of a 340B covered entity? The first requirement, and this is a requirement that manufacturers have a right under the statute to audit for, is the prohibition against diversion. There, covered entities cannot resell or transfer a 340B drug to a person who is not a patient of the covered entity. And the current definition of patient is from 1996 guidance that HRSA put out, HRSA being the agency that administers the 340B program. Basically, that definition requires that the covered entity have a relationship with an individual such that the covered entity maintains records of the individual's health care and that the individual receives services from a healthcare professional who is an employee of the entity or provides care under contract or other arrangement with the entity, such that the responsibility for the care provided remains with the covered entity. And for those covered entities that receive grant funding, there's a further requirement that the care that the covered entity gives is consistent with the service or range of services for which the entity receives federal grant funding. Now, this patient definition has been controversial over the years. There was a 2007 proposed definition that would have narrowed this, but that proposal was never finalized by HRSA. More recently, a new proposed patient definition made it to the Office of Management and Budget, but then never made it out of that office, and so that new proposal wasn't finalized either. The GAO and other commenters have noted that there are ambiguities here. For instance, what does responsibility for care remaining with the covered entity really means. What does that really mean, and what does providing care under other arrangements mean as well? As recently as this fall, Commander Pedley, who heads the relevant part of HRSA, the OPA, said that a new patient definition will be issued in the near future, and Congress members have been calling for updates in the patient definition too. So this is a key definition to the audits that we'll be talking about here. And one reaction which an astute observer might have is, well, given the ambiguities in this definition, why are we even talking about audits of 340B covered entities? What could be out of bounds here? And I think there are some areas, though, despite the ambiguities that have been pointed out, where it really does look like a 340B covered entity could be out of bounds, where it could be said to have sold to a non-patient. So that could be, for example, using 340B drugs for individuals for whom the covered entity does not maintain healthcare records. That seems pretty straightforward. Also, using 340B drugs purchased for inpatients. 9 times out of 10, it should be pretty clear whether someone was an inpatient or an outpatient. So those are just a couple of examples there. And then the second requirement and the second grounds for manufacturer audit under the 340B program is the prohibition against duplicate discounts. And here, manufacturers are not required to provide a discounted 340B price and a Medicaid rebate on the same drug. The 340B statute required HRSA to create a mechanism to make sure that manufacturers did not have to pay these duplicate discounts, which makes sense since the Medicaid rebate is itself a deep discount and the 340B price is itself a deep discount, both of which are based on the same Medicaid calculations. So were both to be assessed, it could well end up with the manufacturer paying for the privilege of having a covered entity buy its product. So again, this exclusion file has been created, and this is an area too where actually HRSA has spoken very recently. They put out a notice just last month where they reiterated some of the basic requirements here, namely that covered entities have to tell HRSA by providing their Medicaid billing number at the time they enroll in the 340B program if they're going to purchase and dispense 340B drugs for their Medicaid patients. And these are called carved-in arrangements. This information then gets added to the exclusion file, and at least in theory, would then be used by the Medicaid program to know that claims from that provider number, that carved-in provider number, should not then be used to generate Medicaid rebates. HRSA also gives in that February guidance some detail about, if you have one covered entity with multiple clinics and some want to carve in and use their 340B discounted drugs for Medicaid patients and other clinics that do not, then there needs to be enough detail on the Medicaid provider numbers in order to allow that to happen and to be able to track that in the state's systems. HRSA also notes in that recent guidance that if an audit reveals that a covered entity's information on the HRSA Medicaid exclusion file does not reflect actual billing practices, the covered entity could be found in violation of the duplicate discount provision and may be required to repay manufacturers here. And one last note on sort of emerging issues here. Recently, some 340B covered entity representatives and public forums have suggested that the current exclusion file is for some reason insufficient to identify Medicaid managed care claims and those covered entities that are using 340B drugs to generate to bill for Medicaid managed care drugs. The issue there is that before healthcare reform, there was no federal Medicaid rebate on Medicaid managed care drugs. After healthcare reform, there is, to the extent there's not also a 340B discount at work. So, that will be an area to watch to see whether any update in the exclusion file is necessary here. And with that background out of the way, I will turn it over to Jonathan to talk about audits.
Thanks, John. So why is this a good time to talk about audits? This, as John had alluded to, this is a program that has been around for decades, but is finally drawing more interest within the last few years, and specifically within the last 12 to 18 months. I think the ball started rolling here along with a GAO report that was issued in the fall of 2011. That noted both the growth of the program in terms of the number of covered entities that were participating and the growth in the number of contract pharmacies, and generally criticized the lack of oversight by HRSA here. HRSA guidance that could use clarification in some areas, and the potential for diversion. And when you look at the actual numbers, they are staggering in terms of currently we have over 20,000 covered entity sites participating. That's 1/3 of all hospitals in America by the GAO's estimate. And in terms of the growth of contract pharmacies, this was spurred on in part after there was guidance from HRSA in April 2010 that each covered entity could contract with multiple contract pharmacies. In just 1 year after that guidance, we saw an even more dramatic increase, as you see on the slide, over 160% increase. Why is this important to us? Well, as the GAO itself pointed out, the increased use by contract pharmacies and hospitals lead to greater risks of diversion. And so to the extent that that the GAO itself observed that HRSA's oversight was insufficient and that we were relying on self-policing, I think all stakeholders kind of have their ears perked up about what they can do better. As John had also alluded to, the program has both been in the news and drawn attention from Capitol Hill. Particularly over the last year or so, Senator Grassley, along with Congressman Pitts and Cassidy and some others, have really been pointing to some concerns about the program in terms of lack of guidance, and also asking for more clarity in the patient definition and more transparency into what HRSA is doing in terms of oversight. Perhaps spurred on by all these, I would note as well, as I imagine many of you are probably familiar, there was a white paper issued last month by a number of industry stakeholders, including Biopharma, Community Oncology Alliance, National Community Pharmacists Association, and others, that cited concerns about the program, including explosive growth of the program, the potential for diversion here, and the need for increased guidance. That was picked up by some major news outlets, which put probably more visibility and more pressure on everything. I would say as well that the safety net hospitals for pharmaceutical access responded to that white paper. They disagreed with many of the characterizations in the stakeholder white paper, but they also agreed that more guidance from HRSA would be helpful here. So I think many stakeholders are aligned around that key point, although they might disagree on what they prefer the guidance to be. With that in mind, HRSA has long allowed manufacturers to audit covered entities, but but they've rarely been engaged in that process. But last year, HRSA began auditing. So last year, we know that they engaged in 51 audits of covered entities. More and more, we've been waiting to get more information about how those audits have been going. In fact, there were members of Congress who, in the end of January, specifically sent a letter to HRSA and asked for more transparency in terms of what we had with audit results. And last month, HRSA released its first public information about its audit findings. They released a chart which is available and which we will also provide with our program materials that show results from the first 18 audits. We don't have much detail here. We know that for 16 of the 18 audits, they didn't cite any findings. For 2 of the audits, they have findings of, quote, inaccurate database entry. And they say that there's a corrective action plan in place to correct that. What that means as a practical matter, we don't know what depth they went into and how involved the process would be to correct. One thing we know historically is that HRSA is short on funding to do audits. So to the extent that they don't have much in the way of findings, at least in the small sample we've seen so far of what they've done, it would lead stakeholders to wonder, well, how deep did the process go? And I think we would like to see a more complete set of information there. Hopefully that will be forthcoming. In terms of what we know about what HRSA did, they have released some guidance on their audit process on their website, and we know that at a minimum, under their posted procedures, they're reviewing policies and procedures of the covered entities. They're verifying eligibility, including GPO and outpatient clinic eligibility. They're verifying internal controls to prevent diversion and duplicate discounts. They are reviewing contract pharmacy compliance, and they're doing testing of 340B drug transaction records, at least on a sample basis. So, at least according to their own guidelines, there should be some meat to these audits. And so we wait, along with the rest of you, to learn more about what's been done, and perhaps learn about the other audits out of those 51, what those results might be. Now, Commander Pedley has also said that she plans to step up the audit activity. So if they did 51 last year, this year they're planning to conduct between 200 and 400 covered entity audits. So that's a real significant increase in volume. One might ask, will they still be able to do that volume of audits given the sequester? And I think that's an interesting point. Clearly, as a non-exempt expense, HRSA is going to feel some budgetary impact on its audit plans, but I guess we'll have to wait and see on that. I would note as well that HRSA has indicated that it's also planning to audit a drug manufacturer in the coming year, so at least one. So we know that this is a two-way street. Next, we'd like to talk a little bit about manufacturer audits. Manufacturers have the right to audit 340B covered entities, as John mentioned, if either we suspect that they, or have evidence or reasonable cause rather, that they've violated the prohibition against diversion or duplicate discounting. The key to HRSA's guidance as a first step of entry here would be establishing reasonable cause to audit. HRSA released audit guidelines in December 1996, which go over reasonable cause and some other areas. I listed some of that out on this slide. I think John is going to focus more on some of that detail when he talks about next steps after the establishment of reasonable cause, so I won't steal his thunder here, but I would say as well that we'll be providing those audit guidelines as part of our supplementary materials, so that can make for some pleasant nighttime reading after this presentation. We know that at least according to the Drug Discount Monitor, at least one manufacturer started auditing a covered entity last summer, and we also know that HRSA is reviewing other audit work plans. So there's definitely some activity here, and manufacturers in different places down the chain conducting audits. So the key to entry here, reasonable cause. What does reasonable cause mean? Well, according to HRSA, it means that a reasonable person could believe that a covered entity may have violated either the prohibition against diversion or the prohibition against duplicate discounting. In terms of how reasonable cause can be determined, that is something that I think Partha Chatterjee is going to talk a little more about.
Great. Thanks, Jonathan. So as Jonathan mentioned earlier, there are two areas by which manufacturers can audit 340B entities. One being the so-called Medicaid double dips, as was discussed earlier, and the other around product diversion. While we'll spend the bulk of our time talking about product diversion, we did think it was worthwhile to spend a minute or two around the double dips, particularly given the information that John shared earlier regarding managed Medicaid and the Medicaid exclusion plan. Sorry. Okay. Okay. So, as mentioned earlier, products purchased at the 340B price cannot also be submitted for a Medicaid rebate. And to be frank, in our experience, checking for this since the inception of the program has been something of a common practice by many of our larger manufacturer clients. As many of you are likely familiar, the approach is somewhat straightforward, whereby you need to establish a crosswalk mapping the chargeback customer to the Medicaid provider number in order to marry up the chargeback data for that 340B entity, and then the detailed or prescription level Medicaid claim data that you can either purchase from a third party or request and receive in varying degrees from the states themselves. In which case then you can identify the amount of volume, reasonably deduce what the amount of volume that was purchased by the 340B entity that was then submitted for a Medicaid rebate. Once that data is collated and once the case can be made for double dips, the next and probably the more important step is working with the state Medicaid agency in question to resolve the dispute. That proactive relationship has been, I could tell you in the years that I've been doing this, that relationship and working closely with your state Medicaid administrator will be huge in resolving these open disputes. In our experience, some states are much more susceptible than others, and I'm sure many of you have your suppositions on the phone. But I will say that the number of double dip occurrences has trended downward over the past several years. And I should clarify that that's not to say that the dollar volume has gone down, however. And in terms of a best practice, if you guys, for those that do not have a current policy in place, most of my clients, again, the larger ones in particular, conduct such analyses about once every year. And just before concluding, while this methodology applies to the Medicaid fee-for-service utilization, there are some changes with respect to managed Medicaid that Jonathan mentioned earlier. So it may make sense to tweak this or your methodology, whatever process that you guys use, to look at your managed Medicaid commercial claim data relative to your 340B purchases. For the operations folks on the phones, I know that this is a bit tricky given the varying quality of the managed Medicaid claim data that you may be receiving. Especially because it may be subject to your contract terms and conditions. But, we expect that as the NCPDP standards continue to get more broadly adopted, it's certainly something that can be done and that I would encourage you to look into. Okay, so the second area, and probably the meat and potatoes of what we wanted to discuss with you today, surrounds where a manufacturer can audit a 340B entity involves product diversion, where the real concern is about a 340B purchased product that is then diverted to an ineligible, parenthetically or in quotes, entity. So not a patient, as defined by HRSA. And really, the scope of what we're talking about are the intra-network diversions, so that is diversion of a product that was purchased by an eligible entity to an ineligible sister site, so that's something that may be occurring at some of the larger networks, or integrated delivery networks or integrated health systems. And out-of-network diversion, so that's diversion of the product to an ineligible institution or patient. And, you know, I think it's important to level set why manufacturers look into this, to be abundantly clear, that we look at it really for three reasons. One, compliance. You know, being a part of the manufacturing community, some people may think that we're not interested in compliance, but as key members in the healthcare value chain, we want to do the right thing as well. The second reason is purely financial implications. As you know, 340B discounts are significant, and if those discounts are afforded to non-340B members, some products can have dramatic and adverse P&L impacts. You know, anecdotally speaking, for one client I have, the 340B channel actually runs a negative gross to net when you account for COGS, royalty payments, etc. If those prices were realized by about 20% ineligible customers, the entire product line would essentially be unprofitable. So the implications are pretty broad from a finance perspective. And then the final thing is around quality and strategy control. Simply put, manufacturers want to ensure the right folks are receiving the right product at the right price. So, as John and Jonathan mentioned earlier, prior to conducting an audit into diversion, manufacturers must establish reasonable cause. And based on the guidance to date, there are really two key elements in determining reasonable cause. One, the identification of aberrant purchasing behavior. And you see the quote from HRSA, that's something that you can look into and use in order to qualify a reasonable cause. And then the second thing is engagement with the customer prior to submitting a formal audit plan. Frankly, that's just good business sense too. And as we'll talk about in a few minutes, it makes sense to work with your customers since they are integral to your success and as you are integral to their success. So, reasonable cause, a methodology. The first thing we should mention is what we are describing is determining reasonable cause and not the actual audit, just to make sure that we're very clear there. And to that end, while we will try our best to provide as much detail regarding this methodology, given the limited amount of time we have, there's only so much we can cover. As John and Jonathan mentioned earlier, if anyone is interested in doing a little bit of a deeper dive, our contact information is posted on the last slide. Now, the second thing we should mention is that this is one methodology, and as we all know, there are many ways to get to the same answer. Furthermore, depending on your portfolio, data integrity, and priorities, the methodology can and probably should be adjusted. Now, that said, it is one we have used successfully for a few manufacturers we are working with and closely aligns with HRSA's risk-based audit approach. Furthermore, it's one that we have had success in leveraging for determining reasonable cause for both covered entities and contract pharmacies. I know with the growth of contract pharmacies and such, that's been a big question. How do we check reasonable cause for contract pharmacies? So as you can see from the slide, this methodology illustrates 5 key phases. We'll do a deeper dive into each phase in a minute, but at the 90,000-foot view, you could see that it embraces the 2 major tenets we discussed earlier. 1, looking at purchasing patterns for your 340B customers in the context of similar customers, and 2, in the spirit of partnership, engaging with the customer prior to declaring diversion. So, let's get into it. In phase 1, or scope definition, what we're really looking to do is answer the most fundamental question of where do we start? I can't tell you the number of manufacturers that have asked me exactly that. I know I want to do something, I just don't even know where to get started. If you're a manufacturer with hundreds of products in your portfolio and sell those products to thousands of 340B entities, it's a pretty daunting exercise. One simple approach we have taken with many of our clients has been to look simply at those products that have the highest volume and for a given period of time have a high degree of volatility in their purchases. As you can see in the example on the slide, the lower left-hand picture, For one client with about 100 products in their portfolio, we were able to determine that about 8 of those products contributed to over 95% of their 340B utilization. And then when we looked at the purchasing patterns for those 8 products, we saw some interesting swings in their month-over-month purchases. I know it's a simple approach, but sometimes simple is good. And it helped in prioritizing these customers by accounting for both materiality to a manufacturer's portfolio as well as likelihood. So once we've established the scope of products, the next phase is really the cornerstone to determining purchasing aberrancy for a particular 340B entity. And it has to do with comparing a customer's purchases to the purchases of similar customers. Putting it another way, it's essentially creating an index. By indexing, we can then make reasonable assumptions about what and how a certain type of customer should be purchasing and compare other like customers to that index. For those of you familiar with government pricing, which I believe most of the participants are, it's not terribly dissimilar than establishing a sort of class of trade where you're grouping like customers together or determining customer of comparability in your CSP disclosure for your FSS prices. Now, I know people are probably muttering on the phone and already asking, how do you group like customers? And to be frank, it's a great question. What we recommend is a combination of 4 categories of metrics: geography, covered entity characteristics, local demographics, and local economics. So let me just talk a little bit about each one. With respect to geography, we would look to group customers by, say, similar settings. So, for example, DISH entities in the Northeast versus those located in Puerto Rico. The second category, in terms of covered entity characteristics, embraces elements such as the number of beds a facility may have or their DISH adjustment percentage. In terms of local demographics, this really addresses the patient population surrounding our 340B customers. For example, for each customer, each 340B customer, we might look to determine the ratio of males to females or the number of adults relative to children. Now, I know some people might be asking, why do we even need to look at that? And the answer is, it really depends on your portfolio. If, for example, you have a product that's specific towards women's health, purchases by an entity with a large male population in the surrounding area might raise a red flag. And the final category of local economics has to do with the potential of 340B volume pull-through. Here we're looking to determine if the surrounding population of an entity look at the surrounding population of an entity and assess their economic disposition. For example, is there a large uninsured population? What's the percent of patients that live below the federal poverty level? By collating these relevant metrics together, you can establish groups of customers that eases your burden in analyzing a customer's purchasing pattern. One final note, if you're a geek like me or like all of us in the room right now, it may be tempting to include a lot of metrics in your exercise. I have to caution you in this because based off of our experience, by including an overabundance of metrics, you could run the risk of establishing such unique groups of customers that meaningful comparative analyses can't be performed. As I mentioned earlier, sometimes simple is good. So I would probably keep that in the back of your mind. Now, once you've established groups of customers, the next phase is to look at the underlying data for each of the customers. This phase is a bit of art and science, with the science, frankly, being the easy part. In this step in the exercise, we would look to plot the volume of purchases of each customer and their groups to identify any customers that, simply put, stand out of the crowd. As illustrated on the slide in the picture on the lower left, we took one group of customers that we established and plotted each customer against their total number of 340B units that they purchased and the volatility of their purchasing patterns. That's a statistical measure. And in our case, our metric, because of the way the data was simply standard deviation. However, depending on your data distribution, other statistical measures can be used like variance, means, comparison, etc. As you can see in the graph, the customer in the red diamond on the upper right clearly stands out as an outlier, purchasing not only a large volume of product relative to its peers, but also having a high degree of volatility in their purchasing patterns. And while we don't know why this customer's behavior is what it is, we do believe it at least warrants some further investigation. As one client put it, it could have just been a procurement person just buying ad hoc or not necessarily looking at their trends. So a couple of quick things to note. In some cases, it may make sense to look at a customer's complete purchasing history, meaning both their 340B purchases and their GPO purchases. The challenge you may face, however, may not be in concept or even in analysis, but in quality or integrity of your data and your customer master. For some clients, linking up a customer's 340B purchases and their GPO purchases prove to be a challenge. Second thing is that while the data may tell one story, we think it is really important to look at the purchasing trends for that customer relative to the group, which is what we depict in the second picture. In this example, you can clearly see the customer, and that's the deep shaded blue line. You can clearly see the customer we identified as an outlier had anomalous purchasing patterns with an abnormal peak and valley relative to its peers. This is where the art of the analysis comes into play. For some not so obvious examples, a subjective but reasonable judgment call has to be made. In our experience, a client recently said, if you look at the same data set too many times, you see 100 different, sometimes contradictory things. So, it's just something to keep in mind if you guys are going through this exercise. Okay, the next step in this phase involves looking at each of the customers we identified for further investigation and really getting to understand their potential for aberrant purchasing. This should be familiar to many of you because it's akin to HRSA's guidance around their risk-based audit approach. There was a release that came out just yesterday that discussed this in varying degrees. And so what we recommend is to apply that same thinking that HRSA is doing by looking at some soft measures such as, for example, historical compliance issues that a covered entity may have had, or financial implications such as have they been in financial distress, as well as the hard measures such as how big the network is, meaning how many parent-children facilities there are, or the number of contract pharmacies affiliated with the parent or the network. Another thing, by the way, which we think is helpful, is looking at the percent of eligible to ineligible entities, which is a very interesting find. Now, if we're just going to stop here, we would have a list of customers that exhibit anomalous purchasing behavior. But if you recall, the second tenet in establishing reasonable cause, as we believe, and I'd like to think makes sense, is working with the customer directly. So that's where we go into the next phase, which is customer engagement. We believe that it's key to reach out to your customers on the sincere basis of collaboration. Remember, we're working with our partners, our channel partners. We're not doing much more than that other than trying to make sure that we all understand the program appropriately and that we are all trying to do the right thing. So it's important to remember that while the data says one thing, to round out the picture, the inputs from the customer are going to be key. In terms of those customer discussions, we recommend a couple of things. One, establish a scorecard that can be used to objectively measure a covered entity's practices. While there'll be some level of subjectivity in populating that scorecard, at least having consistent criterion to evaluate each of the customers that you're working with will ensure at least a reduction in some of that bias. The second thing is use reasonable judgment. Remember, you're doing this in the spirit of partnership, and for those that know me, and speaking from experience, it can be easy to fall into that bull in a china shop sort of mentality. And what we really want you to do is think about how you're working with people that are providing health care or entities that are providing health care to your patient base. So the final step in determining reasonable cause is the simple task of collating everything together into one nice, neat, bundled package. I know it might seem silly to bring it up, but I do so because, one, it requires work, which people tend to forget about, but there is some effort there. And two, this is what your independent auditors, the OPA, your management, and counsel will see at the end of the day. And really, the key to this phase is working with your internal and or external counsel to ensure that, for lack of a better way to phrase it, all of your I's are dotted and your T's are crossed. In my experience, Counsel can really help you on figuring out the communication plan, so keep that in mind, as well as what your next steps may be. And I share that with you not because I am in a room full of lawyers at this point and I feel obligated to do so. And then finally, it's just in speaking about next steps, I'm going to turn it back over to John, who will share next steps when conducting an audit.
Thanks, Partha. So assume a manufacturer has identified several covered entities with unusual purchasing using Partha's approach or some other reasonable approach, and these covered entities haven't provided a good reason for the purchasing levels in the sorts of informal conversations that Partha mentioned. What next? Well, if the manufacturer wants to pursue an audit, HRSA's guidelines are clear. A letter should be written to the 340B covered entity, and that starts the clock on the 30 days of good faith efforts to resolve the matter that HRSA's guidelines require. And the letter could explain the area of potential noncompliance. Is it a duplicate discount issue? Is it a diversion issue? The reasons why we think there might be a problem here, and that we're serious. We might pursue an audit if we don't have a response back. And as Partha mentioned, this sort of letter, definitely a good idea to work with your internal and perhaps your external counsel with on. Other tips here, HRSA guidance is clear that manufacturers, even if they get to the point of having, even if they think they have reasonable cause, they must continue to offer the 340B discount to the covered entity until HRSA says otherwise. And manufacturers should also document the communications with the covered entities, again with an eye towards documenting that good faith effort to resolve the dispute. So what are some outcomes here? The covered entity might give a satisfactory explanation for the purchasing, in which case, no audit. However, if the covered entity doesn't, then the manufacturer can file reasonable cause documentation and an audit work plan with HRSA. Now, reasonable cause, we've already talked about what that involves, and I hope we've shown that this is not the insurmountably high bar that I think many may have assumed it was. Looking and thinking back to that HRSA guidance that Partha mentioned, it's the standard is that a reasonable person could believe that a covered entity may have violated the duplicate discount or diversion prohibitions. And also in that HRSA guidance, aberrant purchasing patterns along the lines of what Partha mentioned, and even complaints of diversion that have gone unanswered by the covered entity should suffice here. The audit work plan also gets submitted, and that's a pretty straightforward document, but again, not insignificant either. I guess that's something that the independent outside auditor would put together. Objectives, scope, systems and processes and procedures to be examined, interviews, timeframes, methodology, those sorts of things are outlined, and HRSA's guidance does a good job of summarizing what it expects there. And again, as Jonathan mentioned, we're going to be providing that as part of the ebook. After that submission goes into HRSA, HRSA has 15 days to respond with any suggested changes to the work plan. And assuming HRSA raises no concerns, then the 340B covered entity gets 15 days notice after a manufacturer decides to commence the audit. So that then would begin the audit. HRSA's guidance suggests it expects audits should not last more than a year. And once the audit is completed, the covered entity has 30 days to respond to the audit findings. And then the manufacturer, under those HRSA guidelines, must submit the report and the covered entity response to HRSA. So what happens after that? And what should a manufacturer hope to accomplish here with a 340B audit? Ultimately, there are a couple of aims here. One is the refund of any improper 340B discounts And another potential outcome is the exclusion of a 340B covered entity from the 340B program. That exclusion remedy has been exercised very infrequently, only twice according to the 2011 GAO report that came out on the program. And a refund, I suppose, is a more likely outcome. So then, with a audit finding in hand that a covered entity may have violated one of these prohibitions, the manufacturer could seek help from HRSA. Should the covered entity, drag its heels in issuing a refund here. Given the increased scrutiny of the program that Jonathan mentioned, I'm more optimistic now than I would have been, say, a year ago about the likelihood of HRSA, taking some steps were an audit report to come back and find possible violations here. It would seem they might get an earful from Congress if they did not. I think it shouldn't be underestimated here otherwise another benefit, and that namely is gaining insight into how covered entities have been interpreting some of the murky areas of the patient definition. Manufacturers could use those findings to help educate HRSA on how covered entities have been interpreting that and to request clarifications, are those particular interpretations okay or not? So with that concludes our presentation, and we are happy to take questions from the audience. As mentioned before, it's the chat feature on your WebEx that is how you submit those questions, and I'm happy to see that we have a few here, and we'll try and get to as many as we can in the remaining minutes. So one question that I had seen come in here is whether the analytical approach that Partha talked about to identify possible diversion, would that work in analyzing contract pharmacy arrangements? So that's the first question, Partha.
Sure. So it does, and in fact, in our experience, we've for some of our clients that we've been doing this type of work for, that was a concern initially because given the nature of contract pharmacies and the data, the quality of the data, and so forth. And by the way, I should mention that there's a timing issue here, right? What years you're looking back at versus today, a snapshot in time of today, moving forward. But it does work, and in fact, for some of our clients, we've been able to identify that not only was there evidence of aberrant purchasing patterns by, say, the covered entity, but by its affiliated or associated contract pharmacy. So yeah, we do look for that as well in this approach.
And here's another question too. How responsive have you found covered entities to be in working with manufacturers in requests?
So, believe it or not, very responsive. For some of our clients, what we've done is that, it's a simple phone call by either their account management people who are working with the 340B entities or issuing a letter, and really, again, positioning it in the spirit of partnership, saying, look, we want to make sure that we're okay in terms of your understanding of the program, our understanding of the program, and we want to work with you, and we just want to get together for a couple of hours to talk about some specifics. And we've actually had a very positive response by most of the covered entities that we've reached out to. I will say there have been a few exceptions, and they've been notable. Repeated correspondences and repeated inquiries, and we haven't had much luck in getting any feedback or hearing back from them. So I would say, 90% of those that we reached out to have been pretty warm and receptive.
There's another question here. Do you anticipate clarity in the patient definition coming soon?
I think certainly we're hopeful that we're going to get some clarity in the patient definition. I know that Commander Pedley has stated publicly that they were working on it and that it's coming soon. As dating back to last August in a recertification webinar, and then in subsequent industry conferences this past fall and earlier this winter, and with several congressmen also asking specifically for clarity in this area. I don't know exactly when the timing would be, but I think, I'm hopeful that we're likely to get clarity soon.
Okay. Thank you, Jonathan. Let's see, let's find another one or two here in the remaining minutes. How do you think the sequester will impact OPA's audits?
I can try to take this one. I think that, it's difficult to say precisely how the sequester is going to impact the audits, but we know a couple of things at least. We know that already HRSA is not terribly well funded, and so the cuts overall would have been HRSA is non-exempt from the sequester. So the cuts will be affecting, it will be a 5% effective cut in non-exempt, non-defense spending in the fiscal year. But it's important to note here that the fiscal year only runs through the end of September 2013. So essentially the sequester has to phase in what would have been 12 months of cuts over the next 7 months. So therefore, the sequester is expected to be 9% for non-exempt, non-defense programs. So a 9% cut in the current amount of funding that HRSA has could have a significant impact on the funds that they have available to do audits. I had said that they made previous statements about doing 200 to 400 covered entity audits this year. I think that's unlikely given the sequester. So what that leaves them with, we're not exactly sure, but certainly less than they had.
And I think that also underscores the importance of, to the extent a manufacturer has a concern, that they'll step up to the plate and consider doing their own audits. With the sequester, it seems less likely that, HRSA should be counted on in this area.
But can I just add one more thing to that? But, regardless of sort of where this may go in terms of HRSA audits, actual formal audits, I can share with you that the experiences that you get in going through this exercise are tremendous. Not to get too esoteric here, but if portfolios are moving in, generally speaking, are moving in the direction of hospital-based products or specialty-oriented products, the channel becomes that much more important to you than they used to be, right? So it's not like the statin market the way it used to be. So in our experiences, by not only combing through the data, but to also engage with the customer and understand how they're behaving, it's almost like a voice of the customer sort of exercise where you're really learning about a key partner that you're working with. And I think it's something that's valuable whatever the outcome might be.
Well, we have one more question here that I think we'll be able to get to. I'll ask it anyway. I'm not sure that we can even answer it, but this would be interesting. Are there any covered entities that you have flagged for diversion that you can share?
No. We can't share anything for obvious reasons. But I think the question also, more broadly speaking, is around that just because one manufacturer may have identified some entities that they believe had aberrant purchasing patterns doesn't mean that those same entities would show up on another manufacturer's analysis. And the reason being, portfolios are different, motivations are different, reimbursement rates are different. Things vary between manufacturer to manufacturer. Now, that's not to say that there aren't learnings that can be leveraged. So frankly speaking, having some experience going through a couple of these is well worth it to be able to have a better running start, I guess, on the analysis. But it's sort of not a cookie cutter approach and say, well, entity A showed up on one client for one manufacturer and will show up again for another manufacturer. It's a little bit more complicated than that.
Yeah. Jonathan Connell is an associate in the same group here at AMP, but he's based out of the New York office while I'm out of the DC office. And his practice focuses on the same areas. He has over 12 years experience in the life sciences industry, and before law school, he worked as a management consultant in the drug industry, focusing on drug price strategy, compliance, and systems integrations. And then finally, we have Partha Chatterjee too. He's a managing partner at the Akara Group. He has over 15 years experience in the life sciences industry, advising manufacturers in a variety of areas, including contracting strategy, government pricing, and reimbursement and contract operations. And prior to founding the Akara Group, he was with IMS Health's Managed Markets Services Practice, Envision Consulting Group, and J&J. So with that out of the way, we'll move on to the presentation itself. Our purpose here today is to discuss manufacturer audit rights and procedures under the 340B program, to talk about how manufacturers can establish reasonable cause, which is a requirement for conducting audits under HRSA's guidance.
I would now like to turn the conference over to Mr. John Gould, partner at Arnold and Porter LLP. Please proceed, sir.
Thank you. Welcome, everyone, to our webinar on 340B covered entity compliance and manufacturer audits. These are important topics, and we feel this is a great time to be talking about them. 340B has literally been making news lately, which is not a common occurrence, and interest in these topics really has been growing, along with 340B program enrollment. So we're excited to be here, wherever we are in cyberspace, talking to you, and I hope you're excited too. So let's get started. We'll start with some quick introductions. With you for the next hour will be me, John Gould, as well as Jonathan Connell and Partha Chatterjee. I'm a partner at Arnold & Porter and the FDA and Healthcare Group. I specialize in compliance counseling, contracting, drug price reporting, reimbursement, public policy advice, focusing on the pharmaceutical and biotech and device sectors, and this includes counseling in the 340B area. All right, well, we will launch now into the background on program requirements. We'll start with the requirements on manufacturers. Equal time for all here. Manufacturers have to sign a 340B pharmaceutical pricing agreement, also known as a PPA, to receive Medicaid or Medicare Part B reimbursement for their covered outpatient drugs. And in this PPA, the manufacturer agrees to charge 340B covered entities no more than the 340B ceiling price for covered outpatient drugs. And again, we'll move pretty quickly through this, but just so everyone's on the same page here. Covered entities include several types of hospitals, such as certain disproportionate share hospitals, children's hospitals, as well as federally qualified health centers, AIDS drug assistance programs, the list goes on. There's also here the 340B ceiling price. That's a deep discount that is tied to the Medicaid prices that manufacturers report under the Medicaid drug rebate program. Given how deep a discount this is, manufacturers have a strong incentive to make sure that they are not offering the discount where not necessary or where they don't choose to do it. So again, this is an interesting topic, the audits, how to make sure that the right entities are getting the right prices here. And again, this requirement to offer the 340B price applies to covered outpatient drugs, emphasis on the outpatient there. It's the same definition of that term as applies in the Medicaid rebate context. In other words, where a drug is used by a covered entity for an inpatient or in a circumstance where there's bundled payment, then that drug is not a 340B drug. And then finally, I'll touch on here ship to bill to arrangements. and what counts as a purchase by a 340B covered entity. It'll be relevant to some of the audit discussions that follow. HRSA guidance instructs that 340B covered entities can engage in a contract, and also to provide some examples of the data analyses that manufacturers could perform in this area. Just by way of background, we'll touch briefly on some 340B program requirements, and we assume that if you're taking the trouble to tune in to an audit webinar, you already have some idea of what the relevant program requirements are. So we'll move through those fairly quickly and then on into the more interesting topics. We will save some time to answer questions at the end, and to do that, we will use the chat feature in the WebEx. So please ask your questions through that feature. We might not be able to get to all the questions during our hour, but please don't hesitate to contact one of us in follow-up should we not get your question answered here. And also, we wanted to let you know that we're recording this conversation, and it may end up posted to our website. In addition, we will be sending out to the attendees materials, the presentation slides, as well as some background documents.